I'd like to thank all the organizers. I would like to catch up a little bit and stick to the timeline. I think it's a great success. Thank you very much for this stunning venue that reminds us of the privilege living in such a beautiful country. Let's take a look at where we are. Well, when I was asked to take part in this conference and I was given this title, I was a little bit skeptical because there's too much to understand and more than what we know. That's why it's important to be here today and to share all of this. Drug treatment is something that is known to all families in different sizes, different protocols, different efficacy grades and rates. Well, I thought I could do something for families. I will do something, I will say something easy, maybe a little bit trivial or not that complicated, but I hope it will be useful in any case. First of all, we are talking about this kind of therapy. This has no symptoms, so asymptomatic disease. There are no specific drugs that are able to change the factors underlying this disease. It's not a root cause that is concerned here, but one of its expressions. What are the goals? First of all, we want to improve the symptoms regardless of their nature. Then we want to prevent any kind of complications like dystonia or the development further stages of a dystonia. And the goal for the patient, but also for the family, and I underline the family, the improvement of the quality of life. In literature, we do not have any studies assessing the efficacy of the drug treatment in patients with the GNAO1 mutation, both for movement disorders and for epilepsy. What we find, what we can say today is referring to single cases, very few patients, or our experience together with the families and the patients. But all this is not put and included into a system in literature. So the efficacy of drug treatment, well, the true scientific answer is we do not know. It's not something systematic. We cannot draw any a conclusion from the timing, from the posology, the doses, and also the association, the combination of several drugs that could be more useful and effective in a specific symptom, for a specific symptom, for a specific group of patients. We are trying to learn something and share things. A registry could turn out once again to be a very useful tool to share something about the treatment, the drugs, so the doses and also the side effects when they are used, better control of dystonia, of epilepsies, etc. So this could be a tool that could be very useful for all of us to draw conclusions to be implemented and carried out in our daily practice. What do we treat and tackle in our patients with the GNAO1 mutation? So dystonia, dyskinesia, then dystonia once again, so this dystonic status dystonicus, epilepsy, but also neuropsychiatric symptoms like aggressive patients, difficulties when it comes to building up relationships, but also sleeping disorders and Shalaria. I mainly deal with movement disorders. These are the three drugs and medications that are mostly used also in other cases in order to reduce all these involuntary movement, these kind of specific writhing movements that have a lot of impact on the quality of life. First of all, anticholinergic drugs, they are mostly used in our practical work, and then we have a benzodiazepine, clonazepam first of all, which is a trade name, but so in this way we can understand each other also. And then we also have dopaminergic drugs like tetrabenzene. These are the mostly used drugs that are used alone or combined with each other. What do the anticholinergical drugs do? They try to antagonize the physiological effect of acetylcholine, and these are a series of drugs that in our clinical practice are the two first. So we have artan and akineton, the two first you can see in the list. I am a neurologist for adults. I had a PhD in pediatric neurology, but what I was surprised by is that these drugs are very well tolerated in children. They do not have a lot of side effects, whilst in adults they are administered in very small quantities and they are not well tolerated. The GNAO1 mutation affected patients can grow up, but we do not know anything about adults. This is another question we do not have any answer for. So if we administer 4 milligrams to a 70-year-old man, we can have confusion and memory problems, disorders when it comes to storing your information, so a lot of side effects. In children, babies under below 15 years, they can tolerate very well all these drugs, and they can have a very advantageous effect, up to 30-40 milligrams, something that could not be done for adults or among adults. So in terms of age, different ages also imply very different quantities and amounts, because we have different side effects. When we say that each and every patient is different, we also make reference to all these aspects because we have no systemic approach. The most frequent side effects that are most acknowledgeable in can be more easily acknowledged in adults than in children are these ones. For example, xerostomia, so not a lot of saliva, and also some problems with the eyesight, and then we also have other stipses, for example, and then urinary retention, something we should warn about also parents, and also children that sweat much less, and also an increase in heart frequency. And sometimes they feel dizzy, they are scared, they are afraid, they have difficulties when it comes to storing new information, etc. Well, we talked about a handbook, handbook for families, a guidance, very, very useful. Also for these side effects of some of the drugs we can use. If I know them, then I can pay more attention in terms of dry skin, for example, etc., or mouth or membranes, etc. Then benzodiazepines, they can be used for very different purposes, and they also increase the GABAergic transmission. This is an inhibitor, and in this way there is a binding with the receptor, and they have a lot of actions. We have a lot of molecules that with an hemilife that is completely different, so the duration of life of the blood, the power is also different, the strength is different, and the administration doses is different, and they are they have a mild relaxing action for the muscle tone. If it's too high, also good for anxiety, and so as anxiolytics, but they also have an anti-epileptic action. The same molecule can be used in very different contexts for many different purposes and disorders. We just have to know why we use it. As all drugs, they can also have a lot of side effects that you can find here, and the tolerance, they also have a tolerance dependence. That is to say, in order to have the same effect, you have to increase the quantity, the amount over time, because the same quantity of drug can have a specific good effect on a symptom, but over time it's not enough maybe, so we have to increase the quantity. And then also the fact that it creates a addiction. We are addicted. It means that we cannot control that kind of symptom in an alternative way if we do not administer the same drug. So we also say that in our doctor's offices, so they get used to these drugs, so less efficacy and the need for an increase in the amount. The side effects are very different. Sometimes we also have paradoxical effects, so not just sedation or hypnosis, but the activation of the central nervous system. For example, when we administer this drug to an 8-year-old man, this is something rare in adults and in children, but for example, an adult or an old man could not could have problems with sleeping, etc. And we can also have a rebound, so a worsening of a specific symptom for which they were administered. So benzodiazepines also have adverse effects, counterindications. Some of them are relative and other ones are absolute. For example, neuromuscular membrane, but also respiratory problems and troubles, so chronic and lung diseases, lung disorders in the alveoli, etc. And this is something that does not happen usually it doesn't happen in children or adults, but this should not be administered if we know that simultaneously they are also taking other drugs that depress, for example, the central nervous system, such as alcohol, because it has an addictive effect. So we have a reduction in terms of functioning of the brain, which is very heavy. Then clonazepam and the midazolam, these are drugs that maybe you know. They are known to all of you or most of you. They are very much used in GNAO1 patients. They have an impact on dystonia, rapid movements, and also when you have when you want to achieve an increase in the muscle tone. And then we also have tetrabenzene. And if we stick to literature, but we do not have any trials, any complete and global trials, these seem to be very effective when it comes to controlling dystonia. And there are some books in which we know that there is no dystonia thanks to this drug, no writhing movements. Everything should be systemized. Sorry, it's not a system yet, and it prevents a synapses to issue dopamine, which is a neurotransmitter that has a lot of functions in our central nervous system. First of all, activation, motivation to carry out some gestures, but it also modules the movement that are carried out when we have a surplus of movements, dystonia. Administering tetrabenzene means blocking the issuance or the release of substances. So we act on the at the presynaptic level, so that no dopamine is released. So dopamine is released. Sorry, and it doesn't. It is not gathered in vesicles, and then it doesn't bind to the receptors. Drugs block the neurotransmitter, and the dopamine is released, but it sits down on the receptor of dopamine. So dopamine is no longer available for this action. So we are talking about the same mechanism in terms of neurochemistry, but tetrabenzene prevents the release of the dopamine. Alloperidol, on the contrary, prevents the functioning for the bound with the receptor. It also has side effects. First of all, you get sleepy, for example, somnolence. This is one of the problems, because even if the quantity is very low, the hydromotor system can be slowed down because it's an activator of our central nervous system. Cocaine and all the other drugs, they have an increase, they bring about an increase of the level of dopamine in our brain, so they activate our brain. And then this slowing down can also be Parkinsonism, for example, when it comes to carrying out gestures or movements, and also chemical deflection, so you feel a little bit, you are a little bit in the blues, so you're not in a good mood, for example. This is something that cannot be prescribed to adults, because if it's not well treated, it can get worse and worse. And also it's not suitable for patients who are already affected by Parkinsonism. All the drugs, tetrabenzene first of all, they do not have indications such as dystonia. So tetrabenzene is very much used also in dystonia. It's off-label, so it's off the official indications for which it is put on the market. This is very important, so it's not indicated in the label. So there is no official indication for these troubles and disorders, even if they are very, very effective or beneficial in the practical in the clinical practice. I'm not an expert in this field, epilepsy, but as far as we know from literature, in most cases we have drug resistance. Even if we have a polytherapy, multiple therapy, we have a lot of seizures, epileptic seizures and fits or grand mal seizures. First of all, we have to say that these patients have a wide variety and range of clinical pictures. They are not all the same. For example, epileptic fit or seizure, and there are no systemic studies that can tell us which one is most suitable for epileptic fits. So you can have an epileptic encephalopathy, so a situation with lots of seizures and fits every day, even if you don't have movement troubles and disorders as main disorders, so you don't have systematic studies. This is a big problem we have to tackle, and we hope we will be also fast when it comes to giving an answer. I skipped one line. The most frequently mentioned drugs are the ones you can see here. So valproic acid, then levetiracetam and carbamazepine. But also here we have a connection between phenotype and the genotype, and the answer to the drugs. So the so-called pharmacogenomics. So same response based on a specific mutation, genetic mutation. Then we talk about Shalaria. We don't talk a lot about that. It is very important to tackle it. In most cases, we use scopolamine, which is an anticholinergic drug. It also reduces the production of saliva, so too much saliva. If I reduce the quantity of saliva, then in some cases I can have an improvement of these scales, of this balance, let's say. Also, from a social point of view, it will be also easier to walk around with my child, with my baby, etc. We do also have some side effects that we have already mentioned. This is part of the anticholinergical drugs, and I say that only because we are focused on movement disorders and epilepsy, but there are also some aspects that should not be in the background. They must also be taken into account. So we do have an overall global to-do list or a checklist where we can say what we want to treat and treat in order to improve the life quality. There is some evidence that these drugs that increase the GABAergic tone in these patients for mechanisms that we have just started to understand. The truth is that we do not have any new drugs compared to the ones we have, or in addition to the ones we have mentioned, and also these ones were not administered, or at least they were administered, but they did not have very important effects. Once again, we do not have any systemic approaches, so we have very few patients. Then dystonia, I don't want to dwell on that, so it's something we have already talked about. Just take a look at the last line. It's quite easy to understand it, but it's fundamental to search for active infections with blood tests and scans, etc. Sometimes when you look for the triggering factor, you can prevent dystonia to further develop, or you can block it. So when the movements increase, you have to wonder whether there is an infection ongoing, if there is an onset, and in case it's needed, you also have to treat it with an antibiotic therapy and a fever reducing therapy. Well, now we talk about long-term clinical outcomes. We do not know anything. This is something I found out 2 days ago. We talk about less than 100 patients worldwide. Many of them are not part of the global literature. This is a pediatric infant disease. There is no study that says and tells us what happens in terms of movement disorders, epilepsy, also intellectual impairments. There was also a question on that concerning the acquisition of skills, but also imaging, so the encephalography, so resonance imaging for the encephalography, and the EEG also in terms of drug treatment, in terms of seizures, fits, etc. This is something we have to work on because there are no answers yet. If there are any answers, there are just spotted answers, so a registry could be once again very useful. And now I would like to share with you, I'm going to skip this one, just is the case of a patient. I have to take the video. This is a patient who maybe, I'm not completely sure, I can't find the video anymore. It was here on the desktop actually. Is there anyone who can help me? This is a patient who is 33 years old with a very long disease history, and it's so long that he has been fighting against his disease for 33 years. Well, it's something, I mean, I'm not that professional actually. This is not the last last update of Windows, but anyway, here we have a de novo mutation, the only a missense mutation de novo. This is a subacute onset of dystonia after a cervical trauma and luxation. Well, in this case he has nothing on and he has a dystonia. This dystonia is a general one. Apart from the dystonia, you see some spasms. Well, he for the trunk, for the limbs, upper limbs, and he also had shock lights. So a kind of shock lights. So we call them a myoclone. So it's a dystonia and myoclone that is quite similar to other genetic forms, and this is the myoclonic form. This patient has never had any epileptic fits. There is no problem with the QI rate, and he has always had a normal imaging, a normal encephalopathy. He is 45 years old and he has 33 years behind him of the history of the disease. When we wonder how are they, these GNAO1 patients, the answer is we don't know. It's also depending on the mutations and the other conditions of the patients. So it's possible that the connections and the development of the disease and the clinical outcome depends on the genotype. That's all from my side, and I would like to thank you very much for your attention.